and welcome to Leadership PRN. This is the Faculty of Medicine's podcast for leaders across the spectrum of clinical and non-clinical medicine. My name is Dr. Lara Hazelton. I'm a psychiatrist and the co-director of faculty development for the Faculty of Medicine. Today, I'm very pleased to have with me Dr. Gaynor Watson-Creed. She is the Associate Dean for Serving and Engaging Society at the Faculty of Medicine. Welcome, Gaynor.
Hi, lovely to be here.
Can you just say a few words to introduce yourself to our audience?
Sure. So I am a public health and preventive medicine specialist by training, so practiced in public health from 2005 up until 2021 when I came to the Faculty of Medicine full-time. And do feel like almost every day I bring my public health training with me into this new position, the Associate Dean for Serving and Engaging Society. So it's been lovely to be able to make that bridge.
Can you tell me a little bit of what the role is, Serving and Engaging Society, what your activities are, your portfolio?
Yeah, the way I have come to describe serving and engaging is, I feel like this is very much the brainchild of our current dean, Dr. David Anderson, who really looked at the Faculty of Medicine when he came into his position and thought, I think, critically about, what beyond excellence in research and excellence in education could we also be doing as a Faculty of Medicine. So maintaining our commitment to those two areas that have always been core for a faculty, I think Dr. Anderson's vision really was around taking the resources of a Faculty of Medicine that are tremendous at a faculty like Dalhousie and putting them into community in a way that might be unexpected, so beyond that research and education portfolio. And so starting to ask hard questions about, how can we be better partners to community in all of the endeavors that help community achieve the health outcomes they're interested in? What are the ways in which we can think critically about how we are training our faculty members, and in particular, focus has been equity, diversity, inclusion, and accessibility. And so those types of things are all part of the portfolio, as well as a commitment to catalyzing systems change. So really looking at how we can be effective systems partners with the health authorities, with governments, with others who are also seeking to do that critical analysis of how they're functioning.
And you mentioned about EDIA being one of the areas of focus for your portfolio. Can you tell me a little bit about what that is? What some of our people in our audience might not fully know what those terms mean.
Yeah, thank you for that question, Lara. I always feel like I put the term EDIA out there and then I have a little bit of and actually we're going to talk about so much more than that when we get into the topic. So EDIA, Equity, Diversity, Inclusion, and Accessibility, is the preferred sort of terminology for all things related to diversity and inclusion at Dalhousie University. And so this is everything from looking at issues of racism in our policies, in our admissions processes, in our hiring processes, but also looking at issues related to disability, related to sex and gender identity, the list goes on and on, related to ageism, so on and so forth. And so we have been using that terminology, but at the same time that we use it, we recognize that that terminology exists in a number of configurations slightly differently depending on where you are. So other universities might use READY, so reconciliation, equity, diversity, and inclusion. Some places are using JEDI, so justice, equity, diversity, and inclusion. And so the terminology starts to matter less as long as you understand really what's behind it. And certainly for us at the Faculty of Medicine at Dalhousie, when we started looking at it, we really wanted to understand that although the conversation that we started with was very much an anti-racism conversation and continues to be an important part of our conversation, we did want to recognize other forms of oppression and how they might intersect and combine. And so I've used the term oppression. That's how we have come to start to describe these different forms of discrimination and really the power differential that exists when those forms of discrimination are at play between one group and another. That has become our focus. And so we've actually shifted away from the language of EDIA now, looking more at the language of anti-oppression in framing this work.
Thinking about anti-oppressive leadership, because this is a leadership podcast, and I hope that people listening to this are often in leadership positions. What do you think anti-oppressive leadership practice looks like?
Yeah, it's a really great question. So, just to extend out a little bit more the definition of anti-oppression, I think it's important to understand that when we start using that language, what we're identifying is a few things. One is that people hold multiple identities. So we can talk about anti-racism, for example, and recognize the identity that somebody might hold as a racialized person. But even as they hold that identity, they hold multiple other identities too. So they may hold the identity of being a woman, like myself. They may hold the identity of being queer. They may hold the identity of being a person with a disability. And in every single one of those cases, that identity will confer either power or disadvantage. And in many cases, when it comes to what we call oppression, we're using that language because we're describing the disadvantage that's conferred by holding that identity. So racialized persons, as an example, would be able to describe the ways in which they are disadvantaged by holding an identity that is not white. So whiteness, by comparison, confers advantage. And so when you start to think about people and their multiple identities, you start to see that those identities intersect in any one individual. So they're not ever only dealing with one form of oppression, usually. They're often dealing with multiple forms of oppression, and it's that intersection of those identities that creates the overall sort of net oppression that people will face. That's what's recognized in anti-oppressive practice. And so when you start to think about those multiple identities and that sort of compounded oppression that folks will experience, you start to think about, well, who are they experiencing that from? What is the power differential that exists between those people and the people who have advantage? And how does that play out? That's really the question that anti-oppressive practice asks. And so anti-oppressive, leadership, I think really similarly needs to recognize that there's a power differential at play, for example, with physicians and non-physicians. That includes patients, as an example. If it is a white physician and a racialized patient, there's another identity that plays out in that interaction. And so you can start to think about the multitudes of identities that play in any interaction that we might have as physicians and how that might confer a certain amount of power over the individual that we're interacting with if we're not careful. And so anti-oppressive practice really seeks to sort of root out what that power differential is and transform it from a power over relationship to a power with relationship as much as possible. So to the extent that you can be provocative in any interaction about questioning yourself, am I really giving this person equal weight in the conversation? Am I really truly grasping what they're saying to me? Or is there somewhere in the back of my head eye rolling happening that I need to check myself on? Those are the types of questions that you can ask that start to point at a different approach to an oppressive approach in that interaction. As leaders, I think it's important for us to recognize that even as those things may play out at the individual level, they also play out at the system level. And so that opportunity for systemic interruption of oppression when it's at play is an important one to take up as leaders. So similarly, we might start asking about our business or our organizational practices, right? Are those practices systematically and systemically always keeping a certain group of people oppressed with less power and not giving them the opportunity to have equal power to others in the organization? That's the type of questioning you get into when you start thinking about anti-oppressive practice. Does that help?
Yeah. So I think if I'm understanding what you're saying that there's sort of maybe an interpersonal aspect that leaders might bring where they would look at their own power and how they're influencing others in interactions with them. And then there's more of the systemic view where the leader's trying to apply that same practice of reflection to what's happening in the system that they might have some influence over. Is that correct?
Absolutely. And it can be in almost any aspect of the organization's business. So as I walked through the Tupper building today, for example, I'm aware that coming into the front lobby, as an example, there is an entire wall of portraits that is all largely white men. And then there's one white woman at the end that's Dr. McDonald. And you start to wonder, okay, what does that say, maybe inadvertently, to the people who aren't represented by those portraits, who aren't wealthy, white, male physicians? What does it say to them about their position in this building? That's the type of sort of deep critical reflection that you start to get into if you're thinking about things from an anti-oppressive lens. So some would argue the Tupper building foyer, as an example, is constructed in a way that is a little bit oppressive to those who don't feel like they are represented in that foyer. Okay, well, if that's the truth, then how would we redesign that foyer? So it's everything from our physical spaces to, again, our policies around hiring and admissions. How do we look critically at who are the best candidates coming into our institution, including for the diversity that they bring, diversity of thinking that they bring, and their tolerance for anti-oppressive practice alongside of their, sort of clinical skills or whatever it is we might be looking for. Those are the types of things that we deliberately seek out if we're taking an anti-oppressive approach.
How did you become interested in this topic?
I think in some ways, honestly, as a public health physician, equity-based practice has always been a part of my background. And so certainly in public health, we're all about, sort of looking for root causes of disparities in health outcomes is usually the starting point for us, knowing that those root causes from a public health perspective are often in societal systems of influence. And so that's actually how I describe the difference between public health epidemiology and clinical epidemiology. They're both the search for root causes of disease, but one is root causes at the cellular or molecular level, and in public health, it's root causes at the societal systems of influence. So when you think about that, you recognize that our societal systems, our systems of education, of justice, of transportation, you name it, of employment, of housing, are often steeped in oppression in terms of how they are framed. So racism is a great example. And so when that is the foundation, that we've built societal structures on a racist foundation, then you start thinking about, well, how do you undo that? And so from a public health perspective, it's not a stretch to get into anti-oppressive practice. And so certainly coming into the portfolio at Dalhousie and serving an engaging society and looking again critically at that sort of EDIA mandate that we have, that we share with the university, it was fairly easy to apply, sort of that thinking to that portfolio as well. Having said that, we have an anti-oppression subcommittee at the Faculty of Medicine that they operate under the aegis of the Social Accountability Committee that reports to Faculty Council. And that group has been really excellent at pushing us to look at oppression, in part because, again, we recognized early on when we started the work of that committee in 2020 that although racism was the thing that brought us to the table, there were so many multiple and intersecting forms of oppression at play. We wanted to make sure that we didn't miss the opportunity to tackle those too. And so anti-oppression has been a focus of that committee and an interest of that committee for that reason. I chair that subcommittee of social accountability. And so again, not a stretch to go there given the interest that the committee had.
So it's interesting. So your background in public health has informed the way that you approach this topic. Have you observed that people with maybe a different background, either from a different type of medicine or outside of medicine, approach the topic differently?
Yeah, it's a really good question. I think in some ways, yes, in that if you're not used to looking for, root causes of differences in outcomes at that societal level, it can be hard initially to sort of wrap your head around how would I think about that. So often what I hear from my clinical colleagues is, we can look at root causes related to access to healthcare, for an example, and they can sort of enter at that level, but stall out at but what is causing the differential in the access to healthcare to begin with, right? So they may see that there's a differential there, but not be able to trace it back to those root causes. But there are exercises that we use in public health, and I share them with colleagues regularly. One of them is the 5 Whys exercise that we talk about in public health, where you sort of systematically and regularly sort of go through a series of asking and answering the question why to get at those root causes. There are those types of exercises that once you run people through them, once or twice or 3 times, they start to sort of see the ways in which society is very much constructed around certain, sort of constructs that uphold oppression. And what I find is that once people see that, they can't unsee it anymore. And then they start seeing it everywhere. And that becomes so uncomfortable that I am finding that my clinical colleagues are now picking up the charge around anti-oppression because now they see it. They understand how it's at play, for example, in their part of the organization, in their division, in their department, whatever. And it becomes so uncomfortable to know that and not do something about it that they feel compelled to do something about it. So that's starting to happen. And so it may be a stretch initially for folks if they haven't had that orientation, but it doesn't take long to get there. I do regularly joke that, many of us in medicine come from backgrounds. I didn't. I grew up in a family of sociologists, but my first 2 degrees actually were basic science. They were in chemistry and biochemistry. But we have so many colleagues who have social science degrees in their background. And so I regularly sort of joke with them that if you thought you weren't going to use that background in 2023, you're going to need it more than ever as we take on these anti-oppression mandates.
It's good to hear that there's some advances that you've noticed. Is there anything you could think of that you might like to share as an example?
Yeah, I mean, one example that I refer to regularly is just that, divisions and departments of the Faculty of Medicine really picked up the cause around anti-oppression, well into 2022. And so we have leads now for EDIA, Equity, Diversity, Inclusion, and Accessibility, in several of the departments and divisions. And that formed organically. There was no mandate from the dean saying everybody should appoint an EDIA lead. People just started doing it. And so some of those folks now have committees around them. They often include department heads that are really challenging the department sort of to look critically, again, at their practices and structures. And so we've convened those leads into a working group. And I'm pleased to announce that the working group now has 2 co-leads. Dr. Liz Crawley and Dr. Christy Simpson will be co-leading that working group. And, it's lovely to see that there was so much interest that we could have enough people to form this working group. And when the group comes together, so far, it really has served a number of purposes. But one is this idea of sharing. What are you seeing in your division? Oh my gosh, I'm seeing the same thing in my division. I thought it was just us. I'm glad to know that it's not just us, but what do we do about it collectively? Those are some of the conversations that are starting to emerge.
What can leaders do to educate themselves about anti-oppression?
Yeah, it's an excellent question because, in medicine, the literature on anti-oppressive practice is surprisingly scant. But in our in the literature from our colleagues in social work and in nursing, there's quite a bit of literature on anti-oppressive practice, and it's long been a tenet of practice in those 2 professions. And so I regularly reach across, in particular, to the social work literature because I find it to be fairly accessible around anti-oppressive practice. I would encourage people to do the same. As a matter of fact, Ontario has a beautiful document from their child welfare agency. It is on the provincial government of Ontario website around anti-oppressive practice for the child welfare system. I feel like it's a wonderful primer, kind of how-to guide. There's a list of questions at the end that very clearly state, sort of different questions that you can ask in any clinical encounter, for example, to provoke yourself into sort of an anti-oppressive practice. I feel like within that document, you could take out child welfare system and replace it with healthcare system, and it would be exactly the same story. So that's a wonderful guide, but interesting that it exists for the child welfare system in Ontario, but doesn't exist for the healthcare system. And so I think we have some work to do to build those, primers, those resources for medical practitioners, but they do exist in the other professions. And so I do encourage people to engage with that. The other thing that I think people will start to see is our national bodies, the Medical Council of Canada, the Royal College, the College of Family Physicians of Canada, are all looking at anti-oppression now as a framework to be incorporated into their various, licensing programs. And so I think we'll start to see the documentation, the resources associated with those programs roll out over the next 2 years. And so it's exciting to see that work starting as well.
I think here at the Faculty of Medicine, you also do, for example, some white fragility clinics.
Yeah, so we have a number of resources in the Faculty of Medicine at Dalhousie, including on the Continuing Professional Development and Medical Education webpage, and linked to the Serving and Engaging Society webpage. That lists a number of resources that folks can sort of dive into if, those written resources are the way you want to engage with that type of thing. And so that's one thing. We are regularly out and about doing all kinds of presentations on anti-oppression and different topics within anti-oppression, like power and privilege, and like whiteness as a credential. As a matter of fact, I just did one on oppression and power for the Department of Family Medicine. I'll be doing another one this week for the Department of Ophthalmology. And so we're regularly sort of doing those types of presentations. And then we do have the White Fragility Clinic, which is specifically a space. It's a 1-hour drop-in clinic. We run that every 2 weeks. It's specifically a space for people to engage with the idea of whiteness as a credential, and what do you do with the privilege that's afforded people in an organization who identify as white. And how do you use that privilege for good, if I can put it that way, and not see it abused, as is often the case. And then I myself offer one-on-one conversations with faculty members around whatever topic they're struggling in within anti-oppression, knowing that we have so many other colleagues and resources that we can lean on and draw people into. So in addition to what I've just said, we have the work of Dr. Omisuri Dryden, who's our James R. Johnson Chair in Black Canadian Studies, based in the Faculty of Medicine. This is the first time that has been in a non-arts faculty or non-law faculty at Dalhousie University. And so Dr. Dryden is specifically tackling anti-Black racism within medical education as part of her work, and in collaboration with the Black Health Education Collaborative, which is a collaboration between Dalhousie and University of Toronto. So we have that resource. We have Dr. Eli Manning, who's our visiting scholar in...
So would leaders reach out to these people?
Certainly folks can reach out to those people as well. And again, on their web pages as well, some of this work and resources listed too. So those faculty members are also available.
Is there anything else you wanted to add before we wrap up, Gaynor? I've really appreciated hearing everything about what you're doing and some of these ideas.
I think really that's it. I really love that there is interest in this topic of anti-oppression. And again, I feel like it's one of these things where once you see it, you can't unsee it. And that is very much the point, is that when folks become comfortable at recognizing it, they will find themselves moving towards reducing it. And that's a beautiful thing to see.
Thank you so much. Thank you for listening to this episode of Leadership PRN. If you would like to be interviewed for the podcast, or if you have ideas of who you'd like to hear me interview or topics you'd like to hear covered, please reach out to me at lara.hazelton@dal.ca or lara.hazelton@nshealth.ca. Until next time, take care.